Thank you. Good to be here like I am every month. I am talking today about the treatment of depression in late life, so we can really focus on that. I have no full disclosures to make. I wish I did. So just before we get started, I always like to share why I like working in geriatrics and in geriatric psychiatry specifically. And this sums it up well from Socrates. I enjoy talking with very old people. They've gone before us on a road by which we too may have to travel. And I think we do well to learn from them what it is like. I think that speaks to the idea of wisdom, another hot topic in geriatric psychiatry, maybe for another time. So I have one objective today, and I want to get straight into it. It's very simple. Know the treatment options for late life depression and factors to consider in selecting your treatment options. Let's get straight into it. So what are our treatment options in treating depression in late life? Psychotherapy, medications, and electroconvulsive therapy. There are certainly more novel treatments for depression out there. Those are not as commonly used yet, and for the purposes of this talk, I really want to focus on these three key modalities. So psychotherapy, I don't want to overlook this because therapy is actually preferred by older adults in studies on treatment preferences for depression, and I think people often assume the opposite. So it's important that we have this as a treatment option to offer our older adults where it's appropriate. Psychotherapy can be really helpful in mild to moderate depression and in dealing with depression as an adjustment phenomenon in the wake of life crises, as in grief is a really good example. It can be useful in developing coping skills for a variety of problems, not only depression, and it can actually aid in the compliance with biological treatments for depression and other medical conditions. The psychotherapy modalities that are most evidence-based in the treatment of late life depression are problem-solving therapy, which is exactly what it sounds like, cognitive behavioral therapy, which is a therapy that focuses on changing cognitions or thoughts and changing behavior to impact emotions, because we kind of think of those three things, emotions, behavior, and cognitions, as all linked in this concept of cognitive behavioral therapy. And then interpersonal therapy is a popular test question in geriatric psychiatry. It's has really good evidence base in late life, and it's a therapy that focuses on role changes. And of course, there are many of those that occur in late life, including retirement, including loss of spouse. So that's a really effective therapy as well in late life depression. Problem-solving therapy, in particular, has good evidence base even in the setting of mild cognitive impairment and executive dysfunction. So it's appropriate even in that setting. It is worth noting, as a downside to all of this that sounds wonderful, that evidence-based psychotherapies are often difficult to access in the community and are often used incorrectly. So that's the reality of our current healthcare system and shortage of mental health care. I will say there are some good services out there. The PEARLS program is one that's available in some counties. PEARLS has a nice acronym that I'm blanking on at the moment, but it is an in-home community-based psychotherapy service provided by usually master's level counselors. I'm being handed a prop. It's the program to encourage active, rewarding lives for veterans, but it's not actually just for veterans in all counties. Some counties have programs for civilians as well. And it uses problem-solving therapy, and again, in the home, so that's really great for some older adults. In the absence of being able to access these evidence-based psychotherapies, I want to plug the idea of behavioral activation, which is actually its own branch of therapy, but is something that we as providers, even non-psychiatrists, can do a lot to encourage. Behavioral activation is based on the 4 Ps, so this is easy to remember: productivity, pleasure, people, and physical activity. And those are the four things that we know benefit depression that are non-pharmacological, fairly simple things to implement. So anything you can do to increase those 4 Ps or goal setting around those four Ps is in a way behavioral activation, which does have some benefit in late life depression as well. In the case that someone has more severe depression, or simply due to lack of availability of psychotherapy services or non-response to psychotherapy interventions, that's when we want to have our discussion about antidepressants. It is worth noting that late life depression does not have as robust response rates to antidepressants and has a higher relapse rate than depression in younger adults. Antidepressants are also generally ineffective in the treatment of depression related to dementia. There's not good evidence to support their use here. Even though this talk is not specifically on depression and dementia, I do want to just make a few notes about it, and this is one of them. Antidepressants are still used for depression in dementia, sometimes inappropriately. It can be really appropriate to use these medications if one does have a history of recurrent depression and response to antidepressants. That would be a good reason to try use of an antidepressant, even in the setting of dementia, or when non-pharmacological interventions that can help depression and dementia have failed. So how to choose an antidepressant if you've gotten to this point where it's clear that an antidepressant is indicated. Previous response to treatment is our #1 indicator of future response. Family response to treatment, particularly within first-degree relatives. Of course, weighing what concurrent medical problems exist so that side effects to medications can be considered and their impact on those medical problems. What medications is someone already on to look for drug-drug interactions. For some patients, it's important to consider the risk of an overdose in highly risky medications like tricyclic antidepressants. And then keep in mind, right, there is some change to metabolism in later life, so some longer-acting medications may be less appropriate. And then we want to avoid anticholinergic agents whenever possible. So as far as guidelines for general use of all antidepressants, start low and go slow, but go, you've heard it before. We need to use an adequate dose, which is usually similar to the dose needed for younger adults, unless someone is quite frail. And you need to use for an adequate duration, which actually is longer in older adults. There's evidence that older adults take 8 to 12 weeks to respond to an antidepressant trial, as opposed to an average of 6 weeks in younger adults. In general, a good ballpark way to dose antidepressants is start at the half minimal efficacious dose for younger adults and double after a week or two if tolerated. In addition to counseling on all the usual side effects that we think of with antidepressants in a general population, it's important to focus on those side effects with older adults that are typically more common only in older adults than we don't think of as much with younger patients. So when you're thinking about options, SSRIs or selective serotonin reuptake inhibitors are still considered first line as they are in younger individuals as well. They have high efficacy, ease of use, good tolerance and relative safety, and good evidence in an older population. There's some options there for you as far as examples of those go. They're our most common antidepressants seen. So those side effects that are more common in older folks that we don't often think of in younger patients include an increased risk of bleeding. This is due to serotonin having a direct effect on platelet activation, and bleeding would most likely manifest as either gastrointestinal or post-surgical bleeds. Hyponatremia is another side effect that's far more common in older individuals and is due to SIADH and typically occurs within the first few weeks of treatment. Falls and fractures also have been tied to all antidepressants essentially, including SSRIs. And we think many centrally acting medications increase risk of falls in older patients. And then there is some evidence that long-standing use of serotonergic agents may increase fracture risk independently by effect on bone metabolism. So some added risk there. So we often think of SSRIs as being easy and safe to use, and they are, but there are some particular notes on specific agents in late life that are worth noting. Fluoxetine, for example, has a very long half-life due to its active metabolite, and does increase the risk of accumulation, especially at higher doses. So it may not be the best first choice agent for an older adult. Paroxetine is moderately anticholinergic. Likewise, I would try to avoid it unless there's a strong history of previous response and someone is not cognitively impaired. And then citalopram and escitalopram used to be sort of go-tos for geriatric psychiatry, but after the FDA issued a black box warning due to concerns for QTC prolongation, it limited the recommended dose for adults over 60 unless we're doing EKG monitoring, which leaves you with a pretty limited dose range to work with these medications. So likewise, I don't usually pick them as a first choice unless I know someone has a history of response at a fairly low dose of these medications. What does that leave us with? Not a lot. Sertraline. So now you know why sertraline is so popular amongst geriatricians. So SNRIs are the preferred alternative to SSRIs. They're still considered second line as they are in younger adults. Worth noting, they also have that risk of falls and fractures and SIADH. And then other second generation antidepressants also kind of considered second line would be things like bupropion, mirtazapine, trazodone I'm not going to mention, and vilazodone and vortioxetine are newer agents with some limited research in older populations. I don't get to use them being at the VA, so I'm not going to talk extensively about them. They're still new and expensive. Bupropion is generally pretty well tolerated in older adults. It's an activating antidepressant. The one caveat I'd give, as in all patients, is that it may not be the best choice in someone with a concurrent anxiety disorder, as it doesn't benefit anxiety. Mirtazapine is often prescribed in older adults that have concurrent problems with insomnia or anorexia because of the adverse effects of improving sleep and appetite. So for the appropriate patient, this could be a good antidepressant choice. It is worth noting that because of its sedative effect and its antihistaminergic effects, it does have some risk of impact on cognition and fall risk. And likewise, it can also cause hyponatremia. You're probably noticing a trend. I wanted to briefly mention tricyclic antidepressants because even though we don't see them as often, I do still see them with some regularity in older adults, especially with chronic pain. It's worth noting there are two different groups of tricyclic antidepressants, secondary amines and tertiary amines. And I think it's important to know this because of the relative risk that tertiary amines have for older adults over secondary amines. Secondary amines are nortriptyline and desipramine. They are less anticholinergic and less sedating. So if you were at the point where this is the type of medication you had to prescribe, either due to other antidepressants being ineffective, past response to this type of antidepressant, or someone with a concurrent chronic pain syndrome where you are entertaining this, a secondary amine would be preferred if possible. I do want to note they have lots of side effects. That's why these are generally considered third line. Orthostatic hypotension can be really problematic in older adults and increased fall risk. Dry mouth is notoriously awful. Of course, they have a risk for anticholinergic effects. They're sedating, and they have a very narrow therapeutic range requiring what I recommend is blood level monitoring if used for depression purposes at those therapeutic doses because these medications are cardiotoxic and overdose. Just to give an idea, they're all over the Beers criteria for those very points. So what happens if someone is on an antidepressant and they have a partial response at a good therapeutic optimal dose? That's when we consider the idea of augmentation. Augmentation agents that are effective in late life depression are listed above. Lithium, aripiprazole, and methylphenidate all have good evidence if an additional medication were needed. I do want to note that antipsychotics are sometimes prescribed in the setting of dementia, particularly depression with, or sorry, prescribed for depression, particularly depression with psychotic features. And while this can be appropriate, I always say, you know, we should be trying to use antipsychotics if possible. Even in the setting of depression with psychotic features, electroconvulsive therapy is a far more effective and safer treatment for that condition. So these aren't the ideal to turn to. So electroconvulsive therapy, I keep this in here not because you'll necessarily be doing it with patients, but because it's such an important treatment modality in late life depression, and I want everyone to be aware of when to refer or when to consider referring for electroconvulsive therapy. These are a bunch of reasons why this is a worthwhile modality in older adults. Older patients are much more sensitive to adverse effects from psychotropic medications. Convulsive therapy can make it so that medications are not necessary or are needed at lower doses. Psychotic features and the risk of suicide are both higher in late life depression, and both of these would be good indications for fast, effective treatment, which electroconvulsive therapy offers. And then older folks are also just much more vulnerable to those physical and functional complications of severe depression, including dehydration, deconditioning, malnutrition, that can all come from a really severe depressive episode, and again would warrant fast and effective treatment. Also, the addition of ECT to continuation pharmacotherapy may reduce the risk of relapse in treatment-resistant depression. So sometimes it's used in conjunction with medication. I also want to note that unlike medication, that actually older adults don't have as high of a response rate to antidepressants as younger adults do. Older adults actually have a higher response rate to electroconvulsive therapy than younger adults. So this is actually more effective in a geriatric population. So times when I would consider this would be someone with severe treatment-resistant depression after trying several medications, someone who has psychotic depression, someone who has worsening suicidality, or someone whose depression is causing significant functional impairment such that they are not eating or taking medications regularly. This would all be good indications that this is severe depression worthy of a treatment worthy of referral to ECT. One of the things people worry about with referral to ECT is cognitive side effects. These are not permanent. They typically resolve within 3 to 6 months, but older adults and people with dementia or neurological conditions are at higher risk for getting those side effects. We recommend typically starting with right unilateral ultra brief pulse ECT to minimize the risk of that cognitive impairment. And lastly, as far as prognosis and follow-up goes, response rates, again, are lower in terms of antidepressant response, higher in terms of ECT. There is some evidence of need to continue treatment for longer than with younger adults. Don't start tapering a medication after response for at least 1 year, and then do so gradually. Monitor for recurrence for at least 2 years. And then people that have recurrent depression may need indefinite treatment. That's all I got.